Can we start?
Yes, please.
Yes.
Yes, please.
Yes. Dr. Garg, can I start?
Sure, sir. No problem.
Okay. Yeah. Good evening, friends. Welcome to the today's webinar organized by Indian Academy of Echocardiography. It's a continuation of our routine series, and I'm happy to say that today's session is going to be very interesting. We've got a good two speakers, right? Okay, and today's session is going to be clinically oriented. Before I start off, I would like to introduce my speakers, and before that, I would like to thank Dr. Parashar and Dr. Mehrotra for giving us this opportunity. Friends, I have got two speakers and got almost 1 hour to go. First speaker will talk about 20 to 22 minutes, followed by about 8 to 10 minutes discussion. And the same way for the Dr. Garg also, about 20-22 minutes discussion, followed by 8 to 10 minutes discussion then, yeah. Dr. Neetu is going to tell us about the clinical cases about the bedside 2D echo. Dr. Neetu is from Mumbai. She is attached to the Holy Family Hospital, and she is independently running the full show of our hospital. She is a sort of an accomplished echocardiologist, whether it is a pediatric cases or whether it is adult cases, or whether transesophageal echoes or the abdomen echoes. Dr. Neetu, we want to have a good session. It's all over to you. Please
Thank
start.
you, sir. Thank you, sir. Thank you for that introduction. So, good evening, everybody. At the outset, I would like to thank Dr. Parashar and Dr. Rahul Mehrotra for giving me this opportunity. My topic for today is bedside echo in emergency decision making. So, what are the advantages of a bedside echo? It's not expensive, portable, widely available, non-invasive, and most importantly, can be easily repeated. Disadvantages: suboptimal echo images in uncooperative patients, patients who are obese, patients having COPD, patients on a ventilator having an hyperinflated chest, a tachypneic or tachycardic patient, or immediately post any surgery. So what does one do in such situations? A bedside transesophageal is helpful. It's invasive, but minimally invasive versus other modalities. It overcomes the issues of poor image quality. It has better spatial resolution and visualization of posterior structures. Complications: severe odynophagia and very rarely esophageal perforation. So today I'll be presenting few interesting cases which we see in our day-to-day practice. And in the end, I'll be discussing fluid assessment at bedside. So starting with the first case. A 34-year-old woman, history of metallic mitral valve replacement done 6 months back, presented with acute onset breathlessness since few days. Clinically, she was in pulmonary edema and her valve clicks were hardly audible. Her echocardiogram showed reduced disc prosthesis movement with an increased flow acceleration across it, giving a gradient of 53/36 and a valve area of 0.5. A fluoroscopy was done, which showed single disc movement. After due discussion with the family, patient was thrombolized with injection streptokinase. Post-lysis, echocardiogram showed well-appreciated disc prosthesis movement now. There was reduced flow acceleration now. The gradients were 12/5 and the valve area was around 2.2. A fluoroscopy was done, which showed well-appreciated disc movements now. So diminution of a metallic valve click is an emergency. Patients who can perceive the click should be thought about this. Bedside echo is an accurate tool to diagnose acute thrombotic occlusion. Fluoroscopy is both adjunctive and confirmatory. Both these modalities also monitor response to thrombolytic therapy. Going to the next case. 30-year-old male presented with sudden onset breathlessness. His TROP and BNP were mildly elevated. Chest X-ray was normal. ECG showed sinus tachycardia with an S1Q3T3 pattern. Echocardiogram done showed a dilated RA-RV with a paradoxical septal motion. Patient had a mild TR with pulmonary artery pressures ranging anywhere between 50 to 55 mmHg. A thrombus was clearly visualized in the LPA, making a diagnosis of pulmonary embolism. A CT pulmonary angio was done to confirm, and it clearly showed a filling defect, a large thrombus in the LPA. Patient was thrombolized with injection altiplase. Post-lysis, after 2 days, there was no thrombus visualized. The RA-RV were now normal in size and the septal motion was normal. So pulmonary embolism is a great masquerader. It's commonly misdiagnosed as ACS or asthma. It is usually not the first, but repeat emboli that prove fatal. Hence, one has to be alert of this possibility. A mildly dilated RA and RV in the setting of dyspnea with clear lungs should make one suspect pulmonary embolism. CT pulmonary angio is confirmatory. However, if not available, should not delay treatment. And one more thing is a normal RA-RV does not rule out pulmonary embolism. So if your clinical suspicion is high, please go ahead with further investigations. Case 3. 60-year-old woman admitted with acute onset chest pain and breathlessness. She had history of family stresses. Her troponin was elevated. ECG showed ST curving V2 to V6 with T inversions. Echocardiogram done showed apical ballooning with hypercontractility of the basal segments. Patient was treated as an ACS, was stabilized and was taken up for an angiography. The angiography turned out to be normal. After 3 weeks, echocardiogram repeated was absolutely normal, thus making a diagnosis or retrospective diagnosis of Takotsubo cardiomyopathy. So Takotsubo is most common in postmenopausal women. ST elevation, inverted T waves, transient Q waves are known. LV wall motion abnormalities not conforming to a single coronary artery territory are known. There is no epicardial coronary stenosis. It mostly resolves within few weeks, and most importantly, it can recur. The next case. 58-year-old man admitted with delayed presentation of anterior wall MI. He presented with breathlessness and a new onset systolic murmur. The echocardiogram clearly showed a large anterior wall MI. The LV apex was nearly dyskinetic with a large LV apical VSD. Patient underwent a CABG with VSD closure, had a stormy post-op course needing IABP support, but eventually went home. So new murmur appearance after an MI mandates careful screening of the IVS and AV valves. Use all possible views and angulations as these VSDs are difficult to profile. Flow acceleration arising from the septum is a clue. Diagnosis of this complication mandates immediate referral for surgical attention. The next case, a 60-year-old man presented with left-sided chest pain and breathlessness. His ECG cardiac enzymes were unremarkable. Echocardiogram done with an echo probe showed a large left pleural effusion. The classical jellyfish sign was seen, a large effusion with collapse of the lung. So echo helped us to diagnose pleural effusion. Patient was tapped using echo guidance. Fluid analysis turned out to be malignant. CT chest revealed malignancy. So chest percussion is a dying art in need of revival. Blind antiplatelet loading as per protocol for all chest pain patients can be disastrous. Rapid screening of both pleural spaces is mandatory in all breathless patients. Case 6. A 24-year-old man presented with sudden onset breathlessness. He was hypotensive. His chest was clear. X-ray showed cardiomegaly. His ECG was low voltage. Clearly, his echocardiogram showed a large pericardial effusion with a dancing heart. There was respiratory variation seen on the mitral Doppler, and the IVC was dilated. Patient was in tamponade and was tapped bedside. Post-tapping, there was hardly minimal residual fluid now, and the patient was doing well. So pericardial effusion is easy to diagnose on echo and even an ultrasound machine, and hence should be picked up by every intensivist. It's important to recognize the echo features of tamponade. It helps us, echo itself helps us to guide helps us in bedside tapping. A 54-year-old man admitted with history of fever since 2 weeks. He presented with recent increasing breathlessness. He had no past history. Echocardiogram clearly showed a large mobile vegetation attached to the mitral valve and a small mobile vegetation attached to the aortic valve. Patient underwent a DVR. These are that intra-op images clearly showing the vegetation on the mitral valve. So transthoracic echo is a good screening test to diagnose infective endocarditis. In patients where the window is suboptimal and there's a strong suspicion, a bedside transesophageal is an excellent and valuable diagnostic modality. Serial imaging can help us monitor progression of the disease and detect new complications like abscess, which may require urgent surgery. Case 7. A 27-year-old man admitted with shortness of breath. He presented with sharp stabbing chest pain that would worsen during inspiration. Now, every possible view and angulations, all were tried, but the echo image was suboptimal. Now, in this scenario, always think of two differentials. Either there's a large mediastinal shift or there is a large pneumothorax. Echocardiogram repeated with a linear probe on the right side showed clearly shimmering appearance of the pleura, which is normal appearance of the pleura. And on the left side, this pleural sign was absent, which is your lung sliding sign was absent, thus making a diagnosis of pneumothorax. Meanwhile, an X-ray done clearly showed a large left pneumothorax, and then an intercostal drainage tube was put. So pneumothorax can be missed if not suspected. Any patient on a ventilator who deteriorates, pneumothorax should be ruled out. 68-year-old male, diabetic, chest pain since 4 days, presented with acute onset breathlessness and cold extremities. He presented in cardiogenic shock. ECG showed an sinus tachycardia, an acute inferior wall MI, and VPCs. So what are your differentials when a patient presents in cardiogenic shock? It can be a ventricular septal rupture, which we discussed, a papillary muscle rupture, RVMI, or a free wall rupture. Now, one can suspect a free wall rupture if you have a patient getting admitted with shock, a recent MI, and a pericardial effusion. Echocardiogram done bedside, suboptimal images, the patient was very tachycardic, showed a hypercontractile LV function with the patient in failure. Patient was stabilized. A bedside transesophageal was done, which clearly showed a posterior papillary muscle rupture with significant amount of MR. That's a rupture. So suspect a papillary muscle rupture when you have acute onset of hypotension, pulmonary edema, a hyperactive precordium, a mid, late or holosystolic murmur. Now, in 50% of the patients, the murmur of MR is silent. It's very short. That's because of due to very low stroke volume and early equalization of LV and LA pressures. Case 9. A 24-year-old man presented with increasing breathlessness, chest pain, and palpitations since few days. Clinically, he had an hyperdynamic LV apex with a continuous murmur in the left parasternal area. Echocardiogram showed a hypercontractile LV function, aneurysm of the right sinus. There was some echogenic focus, which was attached to the right coronary leaflet. On color flow, the flow was continuous, clearly making a diagnosis of a ruptured sinus of Valsalva into the RVOT. So RSOV should be suspected clinically when your patient is with a wide pulse pressure and a continuous basal murmur. The right sinus rupture is commonest to rupture into the RA or RV, usually associated with aneurysm of the sinus. AR is commonly present. Look for a vegetation. In our patient, that echogenic focus was probably an old healed vegetation. Look for burrowing into the IVS, which may predispose to AV block. Case 10. A 58-year-old woman, known case of hypertension since many years, was on irregular treatment. Presented with severe acute chest pain, which was radiating to the upper back. ECG showed LVH with strain pattern. Her cardiac triage was normal. X-ray clearly showed widening of the superior mediastinum. On echocardiogram, the ascending aorta was dilated with an intermal flap which was visualized. A CT scan was done, which confirmed dissection of the aorta. Patient was taken up for a surgery. These are the intra-op T images. A dilated ascending aorta, clearly the intermal flap. The false lumen over here, which clearly shows stagnant thrombosed blood, and the true lumen. Patient was taken up for a root replacement with an AVR. So in a hypertensive patient with chest pain and normal ECG, always think of dissection of aorta. Echo findings may be subtle. It's always a high index of suspicion. Subcostal and suprasternal views are a must to see for the extent of dissection. 22-year-old woman admitted with dense hemiplegia. MR angiography, Doppler, ECG, Holters, all done were normal. Screening echo done bedside was normal. A bedside echo was performed with agitated saline. With agitated saline, there was clearly a crossover from right to left, making a suspicion of PFO. A transesophageal was done bedside, which clearly showed a large PFO with significant shunting from right to left with Valsalvas. Patient subsequently underwent a PFO closure and is doing well. Now, these are POCUS images of the carotid artery using a vascular probe. Now, both these patients presented with TIA. Now, in this patient, there's clearly atherosclerotic changes, which is seen along the full length of the common carotid with an intima media thickness of 1.84 mm. So, an intima to media thickness of more than 1 mm is clearly a risk factor for atherosclerosis. This is of another patient. This is a common carotid artery, which is extending into the internal carotid artery. Clearly, one can see a plaque, a huge plaque over here. So in all young patients with so-called cryptogenic stroke, detailed echo evaluation is necessary to rule out cardiac source of embolus. Normal echo mandates contrast echo with agitated saline and Valsalva maneuver to rule out PFO with a right to left shunt. Always make use of a vascular probe if it's readily available at your center. The last case. 55-year-old man presented with severe chest pain of 2 hours duration. He had no history of comorbidities. His baseline ECG showed subtle STT changes. He was stabilized. Cardiac triage was awaited. Echocardiogram done at bedside. The echo was nearly normal. A global longitudinal strain was done, which is a marker of subclinical ischemia, which clearly showed the GLS reduced in all territories. The GLS was around minus 10.7. Patient was taken up for an angiography. Angiography clearly showed a triple vessel disease. Patient underwent a bypass and is doing well. So pay close attention to the symptoms of the patient. ECG could be non-diagnostic with a large area of ischemia when opposing territories are involved. Echo is a sensitive modality of ACS. It also helps us to localize the artery involved. Speckle tracking, longitudinal strain, helps us to diagnose subclinical ischemia. Now going to the last part of the talk, assessment of fluid status bedside. Now this itself is a vast topic, but I'll be highlighting some basic points. So first and foremost is the history and clinical examination. Most of the times we can judge if a patient is hypovolemic or is congested. Second is your IVC assessment, which I'll be discussing. Then is your focus of internal jugular vein. Now, this should be done in patients where your IVC assessment is difficult or suboptimal. Now, many a times this is in patients who are obese, who are uncooperative, have undergone a recent cardiac surgery. There's a lot of drains, abdominal drains, patient having a large ascites. In all these cases, assessment of internal jugular vein is helpful. Lastly, focus of the lung, which clearly shows pulmonary edema, B lines showing pulmonary edema, indicating that the patient is in failure, a fluid overload situation. So we all are aware of the ASC guidelines of IVC. An IVC diameter less than 21, more than 50% collapsibility, the right atrial pressure is around 3. Diameter more than 21, less than 50%, the atrial pressures are around 15. And any other permutation combination, the right atrial pressures are around 8. So an IVC 4 to 5 mm and collapsing completely, it's clearly an hypovolemic situation. A dilated IVC more than 20 mm, no collapse, is a fluid overload. The gray zone is when the IVC is less than 20 mm with respiratory variation. The whole question is, can fluids be given now? So how do you assess such cases? Do a bedside LVOT VTI. Then do a passive leg raising test. Check the LV, after 1 minute, check the LVOT VTI now. LVOT VTI variation of more than 12% predicts fluid responsiveness, and this patient will be able to take fluids. Now, these are focus images of the internal jugular vein. This is of a normal patient where clearly your internal jugular vein and your common carotid artery is almost of the same size. This is of a heart failure patient in which your internal jugular vein is nearly 5 times the size of the common carotid artery. And with Valsalva also, there was no change in the internal jugular vein diameter. These are images of the lung, These are images of the lung ultrasound. This is the B lines using the echo probe, and similarly the same patient using a linear probe. The whole idea to show a comparison is that you don't always need a linear probe. Echo probe itself can help you to diagnose B lines. So what exactly are these B lines? This horizontal line is your pleural line. Now B lines are hyperechoic lines which run vertically from the pleural line right up till the base. and they are synchronous with the respiration. Now, these B lines can be, the B lines are mostly because of pulmonary edema, but then they can be either because of a cardiogenic pulmonary edema or a non-cardiogenic pulmonary edema like ARDS. So how does one differentiate at bedside? First and foremost is the history, the clinical history of the patient. Second is, if you give diuretics, you give IV diuretics, if the B lines reduce in size, again, this is a marker of a cardiogenic pulmonary edema. And most importantly, always use an integrated approach. The similar patient, echocardiogram was done with the echo probe. Clearly, there was an LV systolic and diastolic dysfunction, which gave rise to these P lines. So to summarize in the end, just don't look at the heart, look around it and help your patient. Thank you for your attention.
I think thank you, Dr. Neetu, for an excellent presentation. I think you have shown wide variety of cases and you are trying to stimulate rightly so that I also appeal to all my friends, when you go for a bedside echo, right, just don't go as a technician, just go as a doctor, try and help the clinicians, right, assess what is happening there. Is it the cardiac problem? Is it the other problems? And as you are talking about the volume assessment, which is a very, very important topic, I feel, and so-called the responsiveness to the volume challenges is also very important thing in critical care medicine. Very often you see we don't know at what level to stop, whether we should continue give more fluids or should we start the vasopressor. So I think this topic is very, very important. There are a lot of dimensions which needs to be considered, discussed. I think we may keep a one separate kind of a webinar to cover up all those things. But I really appreciate you've got a lot of variety of cases, right? Okay, which one can see in our day-to-day practice. I think for the sake of time, I will move on to the second our today's speaker, Dr. Garg. He's a very senior cardiologist from the Jaipur and is well known in the field of echocardiography. To his credit, there are more than 20 publications in the national and the international journals. He's a very regular speaker in many of the national and international forums, right? And he has been a sort of a very active participant whenever there are very echo conferences are there. He has been a part of our executive committee. He has been organizing secretary when the echo conference was done in the Jaipur, right? Dr. Garg, it's all yours. Let's see what you have to teach us today.
Welcome,
Welcome,
Dr. Jaipal sir, for your kind words. And after such a lucid talk by Dr. Neetu, it's my turn to present two interesting cases. So just a minute, sir.
Yeah, take your time. Take your time.
Good evening, everybody. Today, I am going to present the two interesting cases. Just this my first case is subannular left ventricular aneurysm, the rare cause of severe mitral regurgitation. So I am presenting case of 34 years old male who presented with progressively worsening dyspnea of 3 months duration and with history of PND and orthopnea for 4 to 5 days. There was no history suggestive of rheumatic fever. Heart rate was 116 per minute. Regular blood pressure was 110/70 and JVP was raised. There was pedal edema. In auscultation, there was a grade 4/6 systolic murmur and there was a pain systolic murmur found in the mitral area. This was the ECG showing the LV volume overload, and there was the biatrial abnormality. That P wave here is in the second is positive, positive, and negative deflection of P wave is also there. So this indicates biatrial volume volume overload or the biatrial abnormality, along with some sort of first-degree AV block. When we perform the echo, the transthoracic echo, the parasternal log axis view, it just have a look over here. There was a sac-like or aneurysm-like structure that is bulging into the left atrium, and LA and LV were dilated. These are the dimensions of the LA-LV. So LA and LV are dilated. When we switch on to the colors, there was severe MR here. You can see very well. And in apical four-chamber view, this aneurysm, you can see very well, you can appreciate the huge aneurysm, and the neck is connected with the left ventricle. When we switch on to the colors, you can see the blood is going into the chamber. This is the aneurysm in the systole and coming back into the diastole in the LV cavity, and along with severe mitral regurgitation. This is the size. There is a huge aneurysm. The size is 54 millimeter by 42 millimeter. This modified view was taken just to confirm is there any communication between the aorta and the aneurysm. There was no communication seen as on the 2D echo image, and this is another view just to look for any communication between the this aneurysm and the aorta. And on switching on to colors, there was no communication seen between the aneurysm and aorta. This is a short axis view. You can see the huge aneurysm. There was mild to moderate tricuspid regurgitation, and the pulmonary pressure was in the range of moderate to severe pulmonary artery pressure. That's the TR gradient was around 66. IVC was dilated. So the case was referred to a surgeon, and in a surgeon's note, they mentioned the aneurysm valve was rejected. The aneurysm valve was rejected and plicated with the LV, and mitral valve was replaced. And this is the post-op echo. You can very well see the plicated aneurysm and along with the prosthetic mitral valve. Now I am coming to my case 2. Again, a 26-year-old male, he presented with complaints of the progressive worsening dyspnea for last 6 months and history of PND and orthopnea for 3 days. There was no history suggestive of rheumatic fever. Heart rate was 126 beats per minute regular. Blood pressure was 110 millimeter by 70 millimeter of mercury, and JVP was raised. There was again pedal edema. Apex was down and out, and in auscultation there was 4/6 pansystolic murmur in the mitral area radiating towards the axilla. So the clinical picture was almost same. We again performed the transthoracic echo. Here you can see the large aneurysm along the posterior mitral wall leaflet. So it's a feature of typical submitral aneurysm. In our previous case, this aneurysmal structure was coming from the anterior mitral leaflet site. In apical four-chamber view, the aneurysm you can see along the posterior mitral leaflet. When we compare both the cases, this is case 1, this is case 2. In case 1, the aneurysmal sac was coming, entering into the LA from the AML side, whereas in second case, that is typical of submitral aneurysm, the aneurysm was along the posterior mitral wall leaflet. Similarly, in apical four-chamber view, we can also see this is our case 1 and this is our case 2. So in case 1, again, the aneurysm is along the anterior mitral leaflet, and in second case, the aneurysm is along the posterior mitral leaflet. If it comes to the discussion part, in 1962, Abraham et al. Described 12 patients with an unusual forms of the left ventricular aneurysm, which they termed as annular subvalvular left ventricular aneurysm. These aneurysms arise in two situations, either in relation to the fibrous ring of the aortic wall that we call as subaortic, or in relation to the mitral wall that we call as submitral aneurysm. So based on these, the nomenclature of our first case was controversial to me. If we go to the literature, this case, though submitral aneurysm case, was reported by our own Dr. Mehrotra ji and Dr. Vinayak Agarwal in our own Indian Heart Journal. As per the literature, the congenital submitral aneurysm occur only below the posterior leaflet, and with one more reference showing the submitral aneurysm is a congenital outpouching of the left ventricular wall, invariably occurring adjacent to the posterior leaflet of the mitral wall. So this fits in the criteria. Our second case fits in these criteria. The second case is a typical case of submitral aneurysm, but we are not sure about the nomenclature of the first case. There is, so looking at these, one more reference I try to find out from the American Journal of Cardiology. It says that although the previous reports emphasized the origin of the neck from the posterior mitral annulus, we have documented for the first time an origin from the anterior mitral annulus near the medial and lateral commissures. This location places them in region of automitral intervalvular fibrosa and may wrongly identify them as subaortic aneurysm. However, we believe that their close proximity to the mitral rather than aortic wall and their disruption of mitral wall function with mitral regurgitation should define them in the morphological category of the submitral aneurysm. So basically my purpose of presenting this case was to take the opinion of the house what should be the nomenclature of my first case, as I have sent the case to the Indian Heart Journal as a case of subaortic aneurysm. Definitely this was not the diagnosis, but it's under consideration for the publication, just waiting for the final nomenclature of the case. If we go to the surgery part, the surgeon's note, the surgeon's note showing the large subannular aneurysm extending from the 12 o'clock position to the in the AML to the 4 o'clock position in the AML. So the aneurysm was plicated and mitral valve replacement was done. Thank you for your kind attention. So
I think good two cases, right? Okay. Very rare cases, right? Well presented, right? Okay. And I happen to see two such cases in so far my long span of more than 30 years, right, in the 2D echocardiography. And both of them were like case 2, right? Okay. And that's what the literature also says, right? Okay. And your case 1 was definitely very, very atypical, right? Okay. But at the same time, if you try and recall the definition wise also, that these aneurysms can come from any part of the annulus. Am I right? Okay.
Yeah.
And then, for example, if they talk of the classification also, it could be a single neck, multiple neck, or it can involve the full annulus. So I'm just debating in my mind with you also why it cannot come from the anterior part of the annulus also, right? Okay. So that's the one possibility, though the commonest possibility, what you said as the case 2 is the more garden variety of a submitral aneurysm, right? And just for the viewer, this kind of aneurysms have been described much more common in the African countries, right? Okay, and yes, they have been much more common, and very often you pick them up with the young children, right? Okay. I had 2 cases I was trying to mention. One of that girl went for a surgery. Unfortunately, she did not make it. Right. Okay. You see, this kind of the second kind of a case, but the aneurysm is much more closer to the circumflex coronary artery also. So it can compress the circumflex coronary artery also. And I had a lot of discussion with my surgeon that why did we lose that case, right? Possibly there was an injury to the circumflex artery during the surgery. That was the one possibility, right? Okay, so one has to be very, very careful, right? Okay, and second, that other case, as I said, I'm just trying to sort of a logical extension, right? Was it from the anterior part of the annulus? Because there's a type 3 which can involve the full annulus, as they say, right? Aneurysm. Their possibility was much more from the anterior part of the annulus rather than the posterolateral, right? I don't know what you have to say on that, yeah?
Basically, if my first case is a clear-cut case of submitral aneurysm arising from the AML, then it's okay. Then I can resend the case to the Indian Heart Journal. But is there a common opinion, Dr. Rahul? What's your opinion, please? I think Dr. Rahul has muted.
I think he's not there. Yeah, okay. So what was their opinion from the Indian Heart Journal?
No, but they were saying this is certainly not a case of subaortic aneurysm. You should try to find out some other things because there must be two pathology. There are two possibilities. One is the submitral aneurysm along the intermitral leaflet, and other possibilities, other differential diagnosis they gave the automitral intervalvular fibrosa aneurysm. That is also one of the possibility. So we have to give the exact
What was the surgeon's opinion? What was the surgeon's opinion who operated?
As per him, they mentioned the subannular aneurysm. That's all.
Subannular, right? Means we are talking about the submitral annular, right?
Annular means you can say like that, sir.
Right. Okay. Okay. Because you see, when we talk of the annulus, right? Okay.
But they didn't mention much, sir. All surgeons, they don't bother about all these diagnoses, all these things.
Okay. Right. Any other questions? Yeah.
Subannular aneurysm, the Abraham, that was first to describe all these things. So both the things, the subaortic aneurysm, submitral aneurysm, both the aneurysm come under the umbrella of the subannular left ventricular aneurysm.
Okay. Subannular, right? As we say, right? I mean, an aortic annulus is not really that great, well defined, right? Mitral also comparatively better, well defined.
Yeah.
Right. But yes, that's true. That's true. Yeah. Right. Dr. Neetu, anything you want to mention, or you would like to talk about in any of your other cases? I mean, Dr. Neetu, your cases were all interesting. So what my message is to my youngsters, once you go to the ICU, please look beyond. Try and help the clinicians, right? Or you have a probe in your hand. See that definitely you have gone for a 2D echo, so you will see the 2D echo. Look at the pleura, just put the abdomen, see if any ascites. Put your probe at the look at the urinary bladder. Right, many of the times if you put your probes, if many times when you put your probe on the abdomen, you find that the bladder is empty. So I tell them please not to put the catheter in a hurry because the very common so-called iatrogenic infection in the ICU is a urinary catheters. So all those things also can be avoided, right? And at the same time, as you said, 2D echo can help you for bedside little procedures also. I remember like Dr. Neetu was showing a case. I remember there was one case which we had done a 2D echo pericardial. The family was making up their mind whether to admit, not to admit, and he immediately started collapsing on the table. So we had to do the just immediately pericardial tapping on the table itself, 2D echo guided, and fortunately that person made it then, right? All those things we have to keep in mind, right? Okay, that when we are going, go as a critical person, go as a cardiologist, don't go only as an echo technician, right? And try and have the other part of the teams, right? Yeah. Any other questions? Yeah, Dr. Neetu, would you like to say anything?
No, sir.
Okay, you are happy with your presentation, so you are smiling. That's
I'm
it, right?
happy with mine and Dr. Garg's presentation.
Yes.
All the cases of Dr. Neetu are excellent.
Sir,
I have more cases also.
I think there are not many questions in the chat box, right? I
have one more. I have one more case, sir.
Please go ahead. Yeah, please go ahead.
Yes. Okay, sir. Thank you, sir. So, sir, my next case is ostium primum atrial septal defect with persistent left superior vena cava opening into the unroofed coronary sinus. That is the rare entity. A 40 years old woman who presented with complaints of a 1 year history of shortness of breath. She was sent to us just for echocardiography. When we perform the echo, first of all, we can see the dilated coronary sinus along with the echo-free space communicating with the left atrium. When we switch on to the colors, we can see clearly through the colors the dilated coronary sinus was communicating with the left atrium. In apical four-chamber view, we can see the dilated RA and RB and the large ostium second ASD. There's the ostium primum ASD, and size of this ASD was around 15 to 16 millimeter. When we switch on to the colors, we can see the shunt over here, left-right shunt. There is mild tricuspid regurgitation. The TR gradient was not very much. Just so to look for the reason for this dilated coronary sinus, we performed the agitated saline contrast study. First, we injected the agitated saline contrast in the right antecubital vein. On injecting the saline contrast in right antecubital vein, what we see, and this is basically just a little bit long video, so we'll have to wait. So just to remind, the contrast was injected on the right antecubital vein. So what we see, the contrast is entering in the right side of the heart, and there is some bubbles on the left side that are entering through the ostium primum atrial septal defect. If we see the same phenomena in the apical four-chamber view, here we can see the right antecubital vein, the contrast is entering into the right side of the heart, and few bubbles are going to the left side through the ostium primum ASD. Okay, sir. When we injected the agitated saline contrast on the left antecubital vein, this again the parietal long axis view. Here, what we see, just we have to wait. See, so this saline contrast almost at the same time they are entering into the both side of the heart, and this phenomena again we can see in the apical four-chamber view. The saline is injected on the left antecubital vein. You can see. So the agitated saline contrast is entering into the both of the atria almost simultaneously. So to summarize our case, there was a persistent left superior vena cava draining into the both atria through the unroofed coronary sinus along with ostium primum atrial septal defect. If we come to the literature part of the discussion, the Regev syndrome is a rare cardiac anomaly that was originally described by Regev et al. In 1965 as a developmental complex consisting of termination of the left superior vena cava into the left atrium and absence of the coronary sinus. There was no coronary sinus. The SVC was opening into the left atrium directly, and along with there was a atrial septal defect, and this complex was considered unique to Regev syndrome. One more reference is there. However, the cases with normal atrial septum have been reported where the orifice of the unroofed coronary sinus function as the interatrial communication. So, in our case, the case was published in journal Echocardiography, and our case is unique as in our patient. Sorry. As our case, he demonstrated persistent left superior vena cava draining into the left atrium through the unroofed coronary sinus and the presence of ostium primum atrial septal defect. So both the things, the coronary sinus was there, and the unroofed and the ASD was, both the things were there that have been not reported previously. So I just want to know the name, again the nomenclature of this particular entity, or if anyone of the panelists or anyone has seen the such entity. All the three things are there: the persistent LSVC, unroofed coronary sinus, along with ostium primum ASD. If he has seen such cases, then kindly suggest the name of this particular entity.
I think once again, Dr. Garg, a very wonderful case, right? Okay. Right, to show that it was really a complex case, and at the same time one has to keep the eyes open, right? What I was thinking, that the tissue projecting into the LA made you a little more suspicious. Otherwise, in routine practice, one could have said, okay, I'm seeing a pulmonary vein flow, right? It's possible.
Yes, sir.
Right? I think it would have been interesting if you had shown us a pulse wave Doppler also of that flow, that how did it look, right? I'm just stretching it, right? Okay.
Yes,
right, with the pulse wave Doppler would have been more interesting to put there, whether it looked like a pulmonary vein or something different. And the moral of the story is that when you have a doubt, you need to do like Dr. Garg is trying to teach us very rightly, so that we should try and do the agitated saline contrast from both the hands, right? Okay, to get added information, right? And that presence of mind is required in such cases, right? Which you shown very clearly the importance of doing agitated saline from the left as well as from the right arm, right? Yeah, that's very, very important, right? Yeah, I have not seen such case, to be frank, Dr. Garg, right? Okay. Yeah, I don't know if Dr. Neetu has to say anything or any panelist has to say anything. Yeah.
Sir, I have not seen any either.
These cases, right? Or you do a lot of pediatric cases also, that I thought you might contribute. Yeah. Okay.
No,
anybody from the panel? I think if there are no questions, then I think I can call it a day. Right. Thank you very much to all my viewers. Thanks to the Indian Academy of Echocardiography for giving us this opportunity. Thanks to my distinguished speakers, Dr. Ashok Garg, excellent cases, Dr. Neetu, excellent presentation, wide coverage, very informative. I think we should try and keep one of the webinars focused on the so-called either to the bedside hemodynamics, which helps us in the echo, helping in the hemodynamics for a critically ill patient, and how to assess the volume. We can take it more further. At what point in time we should decide if the volume is enough, or at what point we should say when we should start the vasopressors early. I think that may be a topic for the next discussion. Thank you very much. Right? You, Dr. Garg, Dr. Neetu, thank you to both of you personally, right? Okay.
Thank you.
Good night. Good night. Take care.
Good night, Dr. Neetu. Good night.
Thank you, Dr. Garg.
Thank you.
Nice to see you.
Bye.
Thank you.